introduction. So I'll invite our panelists to come back in. Awesome, look at that. Perfect. So why don't we start with just some quick introductions. And Molly, I'll kick off with you if you don't mind.
Sure. Hi, I'm Molly McGrath. I'm the SVP of Product and Engineering at Allara. We're a care delivery and care management platform for people living with hormonal, metabolic, and gynecological conditions. And we went through the EHR selection process a couple of years ago. I've worked on an EHR that was built in-house and have been sort of in the selection process a few other times.
Awesome. Dhruv?
Hey, everybody, I'm Dhruv. I lead product at Firsthand. We are a tech-enabled services business in value-based contracts to engage and navigate individuals living with serious mental illness to outpatient resources. And prior to that, I was leading product at a care coordination business called Patient Ping, and are currently going through an EHR migration, and kindly asked the PM that's actually the brains behind a lot of our EHR work to join as well. So while I may be able to answer some of the questions, I'm glad that Priyanka is here to really get into the nitty-gritty of how we made that EHR migration decision.
Thanks, Dhruv.
Good segue into, yeah.
Sorry, Bobby. I'm Priyanka Guragain. I'm also at Firsthand with Dhruv. I'm an associate product manager, have been working on our EHR selection process and evaluation for a few months now. As we all know, it's a pretty intensive process. For me, I work really closely with clinicians at Firsthand, working through with our users and as much as our clinical team as well that are leading our build of care model. I also have experience working in different care settings in the past as a non-clinician, so have had really the privilege of working with clinicians in different roles. So that's why it's exciting to be at Firsthand going through this process right now.
Great. Corey, we'll wrap up with you.
Hi, everybody. I'm Corey Vanderwall, co-founder and CPO at Frame, which is a virtual care and coaching platform for family building. We have selected our EHR very recently, as we've added telehealth very recently. My professional experience before this, I led product and analytics at SciAps, a precision medicine, real-world evidence company in oncology. And before that, I led the mobile product team at Athena.
Perfect. Thanks. So why don't, Dhruv, why don't we start with you? So there we go. The starting point for choosing EHR is obviously knowing, what you need. And so how have you gone about developing your requirement set and gaining confidence that you're not missing key elements when you're starting to look for EHRs?
Yeah, we went through a journey here. I think when we had to make our original EHR selection, it was before we were live. It was when, and we have a somewhat newer care model. We weren't doing Medicare Advantage virtual primary care, nor were we doing diabetes care management coaching, which are fairly well established. So we didn't have much of an understanding of what our care model was going to look like for our multidisciplinary team. So in many ways, when we made our initial selection, it was just, what is headless? What is API first? What has a bunch of interoperability integrations out of the box? And what will be able to be implemented fairly quickly? And so, it was very general. And then over the course of 6 to 9 months, we got a much, much deeper understanding from our care teams and our clinicians on what's easy to handle, what is, something that is probably still difficult to handle because it's fairly unique to us, and then what is something that is missing as a gap in our EHR. And so from there, we actually made 2 decisions as we were going doing this migration. We were actually peers and social workers should not be in an EHR. An EHR is actually pretty shitty for folks that are longitudinal, that are non-clinical, that are not diagnosing codes, that are not submitting claims. And we made the decision to actually build our own internal care tools for those folks. And separate from that, like that actually allowed us to have a very clean EHR migration decision or EHR selection decision, which was just, what do we want our clinicians to excel at, and where do they struggle right now? And there, we were able to be fairly precise on, we need meds, like we need interoperability solutions for meds, and we need really good read and write APIs to kind of push data from this internal care tool that our peers and social workers are on to the EHR and vice versa. We need really great performance, and we need like really robust scheduling. Those were the things, and we need like great customized questionnaires. So we were just like, we just went from not knowing to like having a very, very specific set of requirements that Priyanka actually like went and put together with some of our clinical product team. And then it was fairly straightforward. We were just like, okay, like, which vendor has this? What's the pricing that they offer? What's the level of engineering support it'll need? And then we were able to make a pretty straightforward decision about not only like what we thought would have been helpful for us today, but also, the push that I got from my CEO and our board is, hey, like, what is a decision that you're willing to live with for the next 3 to 5 years? Like, we don't want to migrate EHRs a second time. So, now, like, where do you see a vendor that is got great velocity shipping and seems to be investing in our type of use case of like value-based primary care for the clinicians? And then Priyanka, sorry, Bobby.
Oh, go ahead, Priyanka.
I think Dhruv really gave you a very good overview of what we've been through in the last few months, trying to understand our care model and also our user needs. And then obviously thinking about how we scale as we build our care model. Those were kind of key to us.
Gotcha. Do you guys think there's generalizable advice there? Meaning, in the early days when you don't have as good a sense of your requirements, looking for something that's a little bit more flexible, fast to stand up, and anticipating that there's a decent likelihood that you'll need to, or at least potentially consider switching EHRs on the road once you have a tighter sense of what your true requirements are and you firmed up your care model a bit? Or do you think that was kind of more just your specific case, how things unfolded?
It's interesting. I would say the market is so different this year than it was even a year ago. Like if I had to say what were super general requirements that like implicitly changed my decision, it's what's ONC certified. So like there are EHRs that are ONC certified this year or planning on being ONC certified this year that weren't last year. And like that kind of like changes the calculus, but it's basically, what's ONC certified, what is our payer partner who sends us claims data going to be kind of comfortable with. They might enforce some like high trust compliance needs on us now or in the future. So one is certifications. The second, I think for many, like many tech-enabled services providers, is what has great clinical documentation, especially from a like clinical assessments perspective. I think, some EHRs are basically like, here's your PHQ-9 and, like, here's your GAD-3. And you're like, no, like I actually need a very powerful form builder, because we actually do need our clinicians to be able to do great clinical documentation to succeed in a value-based care environment. Like we have very comprehensive primary care visits. I think integrations are really key. So, we use Zeus and I think like we had intended on using Zeus fairly early. And so, you can kind of basically be like, hey, what has good integrations with Commonwealth, Care Quality, SureScript, the labs, like labs providers and ADT providers, and actually like digging in there, because I think some of the EHR vendors can be like very hand wavy with their integrations. People will be like, we have a Health Gorilla integration. And you're like, okay, but do you mean like we can request medical records from Health Gorilla? We use Health Gorilla to e-prescribe. Like, I think integrations is a third one of like being very explicit about the types of integrations that you get. And then I think honestly, like, it's really going to be a matter of what do you think, like which vendor is easy to work with. Like, I think like different vendors have different implementation teams. Different vendors have different pricing. Like there are vendors that we considered this year that we would have never considered last year, because their pricing was just like really high, and it would have been a very like painful pill to swallow had we not known what we know now. So I think those are some of the like high level criteria that I would go with, and that should at least get your solution set down to maybe like 2 or 3.
Makes sense. And Priyanka, I want to come back to you. Since you guys have just gone through this, obviously buy-in from your clinical team is super important. And so just curious if you had any best practices, from working through this with your clinical team on how to best work with them.
Yeah, I think as kind of Dhruv mentioned, we've been live for a year, maybe. I think at this point it's been a year. So we're learning a lot from our clinicians. Our clinicians are really key to that scale piece that we mentioned earlier. So for us, there were really key learnings. First is really like building channels of communications where we encourage clinicians to share with us their pain points that they're having in the current system. We repeatedly heard that, tech teams or just like general EHR systems are not designed to listen to clinicians. And that's just like clinician experience in the past they have with organizations they work with. So kind of using that as a leverage point for us, we continue to have these positive conversations around like, what are your needs? Please share. These are channels we're building so we can continue to learn from you on what your needs are. So that really built better partnership for us. We put ourselves in a pretty tight timeline to understand our like evaluation process. But again, like really coming back to our clinicians to know that like scheduling isn't great, even though that's not really my responsibility. I know it's not great for me. So understanding the second piece, which was like, what else impacts them? Who are their collaborators? We work in a pretty integrated care team, with non-clinicians as well. So what else is happening in their day-to-day? So that was the second piece. We got really granular with our inputs to understand the impacts that they see day-to-day within their EHR or outside of the EHR use. We saw a lot of like toggling back and forth. So again, like building that user empathy kind of continued. And then the third one, as we kind of got further into the process, was really bringing clinicians back in to have a pretty transparent selection process. We have some really good clinical, like leadership and also like user advocates almost. So we made sure like the EHR systems that we were thinking of were something we were already sharing about. For us, like that is probably important, thinking like, all of us know that EHR implementations are known to be hard. There's a lot of change management that goes into it. So bringing clinicians early on into that process and really setting expectations right around going from one system to another is going to be different. It's not going to be the same workflows, same functionalities. So that's kind of where we're at. And those were really the three things around how clinician partnership has worked for us.
Makes sense. Any like super tactical advice on either what worked through that process for you guys in terms of that engagement and that buy-in, or even if something didn't work well, you tried a certain way of getting engagement and it just kind of fell flat? Would love to hear if there's anything that folks can take away from your experience.
Yeah, I think where our product team sits in our organization, obviously we're very cross-functional. We go to markets, we are seeing these things happening live. So that really helped, and even if other folks are going, like our clinical teams are in the market, we ask for the same kind of inputs. So really being in person and really continuing to build other channels outside of that was important. So it wasn't just like sporadic in terms of how we were asking for input.
Got it.
I'll add just like two other things there. Our clinical product team did a really good job of sending surveys frequently on like just like very lightweight surveys on, like what was working well. And that was like feedback that we used with our EHR partners, which I think they appreciated, of just like getting good qualitative user feedback. And then the other thing is like, for the builders here, you have to advocate for your clinical users to the vendor. So I think like, to Priyanka's point, when they see that you have that empathy for them, it's just so atypical of the IT teams that they've historically worked with. So, if your platform is down, or if, clinicians aren't able to like get their work done, like you should be just as pissed as they are, and you need to advocate for them. And I think that actually also went a long way to build trust with our clinicians, that we were we were in the same boat with them, and that we were going to advocate for them as much as we could.
Got it. Corey, coming to you. in your recent EHR selection process, you were able to cut through to a short list of vendors once you started to understand the various archetypes of EHRs that exist. And so I'd love if you could just elaborate on what you mean by different archetypes and the ones that you typically see in the market.
Definitely, yeah. I think I started off our EHR selection process in a place a lot of people do, which is pretty overwhelmed, right? You've got your list of features, the things that you feel like you need. You talk to key internal stakeholders, you talk to others who have made this the kind of EHR selection process, and get this laundry list of too many things to keep track of. And then has been mentioned by a few folks already, there's the depth of each of those features as well. It's one thing to say you have the feature, but then the specifics of, let's say, how customizable a form is, or the level of, how you can brand certain things within the experience and things like that, right? So I was totally overwhelmed. And then I realized really what I needed to do is break it down into what are the EHRs themselves trying to differentiate on, and therefore where are they going to continuously invest over time, and how does that align with where I want to differentiate? And so, there may be different things. There may be one that's trying to differentiate based upon a really great patient-facing experience that is built into the EHR that I won't have to build as a result. Or maybe there's one that's great around kind of the back office stuff that we all hate that EHRs, some of them do really well, billing, compliance, all that stuff. Maybe there's some that pride themselves on being headless, having great API libraries, super customizable, et cetera. And so for us, I kind of went back to what do we really need to do? For us, it was nuts and bolts clinical work needs to be great. And the rest I want to build myself customizably. So how does the clinical workflow work? And can the rest be basically headless for the patient-facing experience? And that really let me then basically make the decision based upon cost and speed to implement once those basic criteria were met.
Gotcha. On the ability to build on top of it, was there anything in particular that you did to evaluate that? Was it just reading the API docs? I'd be curious to know how you got a good sense of, this is an EHR that's great to build on top of.
It's one of those things you don't know till you do. You can certainly read the API docs. You can certainly look at integrations. You can definitely talk to customers that are already using this, look at kind of how they've used it, where they've built on top of it, and whether those companies look like you. I think a lot of the things, honestly, that I'm excited about your product are, things that I was putting together myself, where you could see, here's the APIs for that, and here's the other companies who use this. And yet you're always going to have the gotchas. Just like with any new product, you don't want to invest and assume up front. You want to test and learn and build where you can.
Makes sense. Molly, where have you seen EHR decisions fail? Have you noticed any common patterns, in your experience talking with other folks around why people typically need to switch if the first one hasn't worked out?
Yeah, I think there's a few, there's a lot of reasons, but there's a few that come up more often than others. I think the biggest one isn't so much a switch as it is like people start building it themselves. They just kind of assume you build it yourself and then change their mind halfway through the build, or change their mind when it's like 6 months in and they can't actually use anything and they're not certified, like all the realities sort of hit. So I think one kind of theme is just thinking that it's going to be a bigger differentiator in the overall business than it actually is, especially if you're pre-product market fit, which we made our decision like pre-patients. I think the second one is probably thinking that or not thinking critically enough about what your future roadmap or like future business is going to look like. So I think common for direct to consumer businesses specifically to think they'll never interact with insurance. And so maybe they're not thinking about certifications or thinking about use cases that they really should be thinking about, because the switch is painful and the roadmap is quite long. It's not like overnight, you're going to get that certification, you're going to be fine. And it's a pretty serious stop if you don't have it. And then I think, Dhruv hit on this really well, like not asking for feedback within your org is, if you don't get the clinicians on board, or if you don't know where your, founder or your board is thinking about what you're investing in, that can really change your mind quite quickly. And you need to you might need to change or make a decision to build on top of it or build something new. And I think, as everyone's kind of said, those changes are not quick. And especially if you're in a startup, like, when we started, we were like a few engineers and myself building, and everything else was so quick. But then you introduce this like monstrosity that is not as fast and isn't as agile as everything else. And so the change management of like understanding the expectations around how fast that change is going to be can really come back to bite you when you have to switch.
Yeah, makes sense. Dhruv, I'd be curious to get multiple opinions on this, but Dhruv, maybe starting with you, does it ever make sense to build today? Typically it's been the build buy decision, but you're seeing more headless EHRs emerge. Do you think there's a situation when people should be building or no?
It's funny. Like I will always seek out the like total 180 viewpoint on this, because on anything. And the person that I'll shout out that, is like very staunchly pro just like build your own EHR is the team at Hone Health and Stuart Blitz in particular. And so, Stu will say, hey, it's not that complicated. Like, at the end of the day, you just need to be able to document, and you just need to be able to like submit claims. And even then the EHRs from like a clearinghouse perspective are like outsourcing to, ClaimMD or Purity, like one of these other vendors, and that you can kind of like build the rails fairly quickly. There's something there that I don't like fully understand about why that team, or like why there's like this small contingent of folks that have built their own EHR that are like, this is working for us, and we are kind of like charting the course and doing it fairly effectively. I think that is probably only true in commercial insurance and in cash pay, where you can probably get away with that. I think that in our world of like Medicaid, Medicare, value-based care with the amount of like ONC requirements, I would just never want to deal with that. Like, I think that's probably the bright line. Like if at the point that you just need an ONC certified EHR and you need to kind of maintain that certification, those requirements year over year, like that I will 100% outsource. I think the thing that is probably more interesting from a build versus buy perspective is, where are you putting your non-clinicians? So, like what are the tools that you're building, not just for us, like with our peers and our social workers, but with our team leads and with our like market GMs and with our records request specialists and with our, like clinical documentation folks and our coders. Like there is, what we're finding is actually more and more we're going to build our own tools for those folks, because I think historically ambulatory EHRs that don't have as much of a history as say like your Epics and Cerners and Meditechs probably have really built for clinicians and like physicians and mid-levels, and really haven't built in earnest for all of those other folks. And that's where we're choosing to build internally more, not just our like non-clinical care team members, but everything, and even like care team operations.
Got it. Corey, Molly, Priyanka, anyone else have any opinions on the build versus buy, or when it makes sense to build from scratch these days?
I'm not going to name the company because I'm not sure I'm going to even get this anecdote right. But I was talking to somebody who was moving away from a bought EHR to build their own. And it was because they like the patient experience was being meaningfully impacted by the EHR. So for example, like they were doing gender affirming care, and the EHR would not allow them to choose anything other than he or she pronouns, and it was legal name only. And it was just like really impacting the patient experience that they were very specifically trying to change. So I think when it's things like you're going up against traditional healthcare as a construct and you need an EHR that supports that, like you're probably going to need to build your own. And I think in those cases, that is your differentiator, makes sense. But yeah, I definitely have trouble like understanding otherwise when it's like, I always think it's a little bit, when I hear the argument for it, it's usually like, it might not be as unique as you think, is usually my reaction. And I, maybe similar to Dhruv, I'm like trying to fight against that. I want to like stay open-minded to it, but I haven't heard a ton of good reasons yet.
Gotcha.
My experience with EHRs echoes a lot of comments made, but I think you're always going through, you know, the frustration with what you have, whatever you have at the time. You know, you're frustrated by the limitations of this fairly rigid EHR, which is probably rigid because it has the certifications that you wanted, is the reason you chose in the first place, and you're kind of going around in circles. And I always, with build versus buy, with any tool, always come back to, you know, resources, cost, and where you want to differentiate. You can only have so many bets. I think until the sort of bright lines are crossed with the end user's experience, I think that is often the best argument that I've ever heard to build. But I haven't seen it gone well ever when you build eventually. Even One Medicals of the world, right? Who, you know, I don't think a lot of people are happy with that decision eventually. Maybe some are, but it's certainly a frustration to me as a patient of One Medical. So,
yeah, gotcha. Cool. I want to shift gears a little bit. Corey, I'll stick with you. You know, I think for a lot of folks, the EHR decision can feel really weighty because there's a general sense that it's really difficult to switch from the EHR once you've chosen it. So I just want to get a sense from you. You know, how painful is this really? And is there anything upfront you can do, you know, in the eventuality that you may need to switch an EHR to make that less painful down the road?
Tough question. I think the general sense is probably right. I've never actually had to switch EHRs myself, so I'll just, you know, call that out. I have contemplated it and decided not to do it because I was generally intimidated. I will say that, you know, the ability to switch EHRs and not be tied to any one vendor ever, I think, is important. And so now, as we've thought about what we do next, I have tried to make sure that there are a few things that we put in place that would give us the opportunity to switch if we had to. So a few of those things are, you know, first of all, I actually don't want the EHR to be the source of truth for data for the patient. I want it to be the record-keeping system that then I have my own database that combines lots of information elsewhere. I think that's kind of probably the number one principle that would allow switching. The second is, I don't want to choose an EHR that I need to build a whole lot of custom workflows on top of that are only possible in that EHR, especially not when I need to, for example, hire a bunch of consultants to manage those workflows. And so I want to do, honestly, as little customization on the sort of front end of the EHR as possible. Configuration's fine, but customization is very different. And then the third piece is, you know, coming back to kind of my principles of how we chose our EHR. I want as little communication from the EHR to the patient as possible. If the, you know, EHR is sending messages to the patient and the patient needs to then switch their profile and switch this and switch that, and they're getting it from a different place, that's really interrupting to the experience, and I can't do a lot to change that if I switch. And so, you know, those are kind of the three principles that we're using to give us the option to be able to switch in the future.
I want to come back to you on a slightly different topic. You know, I think it's I think it's fair to say we're moving to a more composable model of building tech stacks, as opposed to historically buying kind of bigger, more monolithic, all-in-one type solutions. And so in this world, integrations become a lot more important. And so I'd just be curious if there's anything that you've learned along the way about evaluating how easy it is to integrate with a given EHR, or when an EHR says they have a certain set of integrations, what does that actually mean, or are there differences amongst them? We'd just love to hear any thoughts there.
Yeah, I think the EHR telling you they have an integration is like the tip of the iceberg. I'm almost always like, not just, I mean, to give them credit, I guess I'll say like, there's not always a shared definition of what the feature is. There might not be a shared definition of what like exactly the API can do. And so, and that's maybe a little generous, but I think often you're sold like what they might do with the API in 6 months. So to get around that, I think the API docs like being on the feature level in your demo is something I'm very excited about. I think I'm always like, if I'm not building it with my own 2 hands, I'm going to send it to the person who is and say, it is like this requirement. I'll write up tickets of it and say, if I wanted to do XYZ with this EHR based on these docs, do you think that's feasible? Where is the pain going to be? So if it's something that's super, super important, I'll go that far as to almost make it seem like it's an actual request we're doing, and we'll mock it out. And I think I'll typically, or not even typically, like almost always, I'm going to find somebody who has that use case, who is using that exact vendor, and try to get in the phone with them. That has been such a huge help. And I think to Dhruv's earlier point around like looking for vendors that are investing in your use case, I think the hand in hand with that is like knowing your use case really well and finding other companies that have your use case or are willing to like speak to their experience building that use case. And I think that de-risks the integration points a lot, and can make you get really comfortable with them. And then I think there's also something like, looking at if obviously you integrating with them is one thing, but like in this idea where like, for example, we've been using Source Health on top of our EHR. And we made sure that like both parties were very aware that we were doing that they were comfortable with it, that, the newer company was like going to work with them. So I think just being super transparent about how you're using it and where you want to integrate. I think when you do that with a vendor, they're just more comfortable. They're going to be more honest about like, okay, you're actually about to do this. Like, we're going to tell you if it's going to work or not, because usually they kind of know. So we would say like, okay, we're actually going to, send this data in this exact format. Does that make sense? And we got some really clear answers. So I think being as specific as possible, and as transparent as possible with them can go a long way.
Makes sense. Dhruv, I saw you smiling and nodding along with that. Anything you want to add from your perspective?
No, like I think that there's always going to be some trade-off in whichever vendor you use. Like us going through this, migration right now, we're going from a smaller EHR to one of the bigger players. And I think kind of like going in with a very probably like skeptical and discerning like buyer perspective is necessary, very much to what Molly said, like trust but verify. Because there's always some trade-off that you're going to experience in the end-to-end delivery of what you're trying to accomplish. So like some of the smaller EHRs, not as robust in their capabilities, but really collaborative, really responsive. Like they'll set up a shared Slack with you and you'll just be getting like, like real-time feedback, which is really valuable in its own way. This new EHR that we're working with, they did not give on 99% of the things that we asked for in contracting, and they are much more expensive, and we're going to spend a ton of money on implementation, and they're slower to respond to us. I'm like, it's blowing my mind where I'm like, we were going to pay them more, like just as much money as we probably spent on our other EHR in year one, and they just generally seem slower in responding to us. So, the capabilities might be like, more out of the box, but we're probably just not a big contract to them relative to like other customers. So I think it's like, kind of going in with that perspective of, hey, like, what the vendor says doesn't matter. It's the end-to-end delivery of, is it live in production that your clinicians are using, and just kind of like staying focused on that and not giving any, like, I think like assumption that things are just going to organically happen is like really critical, regardless of what kind of EHR you're using. I think like you just have to be really maniacally focused on shipping there. I don't think that there's any magic pill solution on the market that solves that.
Makes sense. All right, we've got about 10 minutes left, so I wanted to open it up to Q&A from the audience. Looks like we've got one question already from Molly. So Molly, why'd you decide to go with Source on top of another EHR?
Yeah, so I think our EHR works great for like clinical workflows, in-visit workflows. So like charting, ordering labs, prescriptions, having, you know, working with insurance, things like that. Source almost operates as like async care CRM type of tool. And so combined, we found that Source was a way to like make our EHR a little bit more digital health friendly and feel like the care was more ongoing. And so far, so good with that.
That's good. If anyone else from the audience has any questions, feel free to drop them in the Q&A. In the meantime, I will keep asking questions until we get more. And I'll put this one out for anyone on the panel, but are there, kind of in line with the last question, but are there any common feature areas where you see people most commonly augmenting their EHR? You know, whether scheduling or task management or communications or anything else, but are there kind of commonalities that you guys see as you talk to other builders in the space?
I think like, you know, one that's come up a little bit is interoperability. And I think that like that is a very hard kind of category to define. But I think if I had to say like, what are some key interoperability things that, you know, you should expect out of your EHR, and you should be very pointed in this, there's probably 3 or 4. Med lists from likely SureScript. Like your clinicians should not have to populate a patient's medications. That should be made like fairly easy from, you know, medication lists just coming straight from SureScripts, and your EHR should handle that. Medical records from Commonwealth or Care Quality. Like when people say that they have a Health Gorilla integration or a No2 integration, or even like a direct Commonwealth or Care Quality integration, like that should explicitly mean that you can query medical records and get them in some form in the EHR and the patient chart. ADTs from like a Bamboo or a Collective Medical to enable a transitions of care program. Like you don't necessarily need to integrate with every single HIE that could be a provider of ADTs, nor even like some of the bigger vendors. You should just be able to get that either through a direct EHR care management integration or through like some aggregator integration. Those are like the really big ones that come to mind from an interoperability perspective, where I think like that should be coming from your EHR and be embedded into the care workflow, as opposed to you having to build that yourself.
I think the other one that sticks out for us at firsthand, but also in my past, like different clinical verticals, has been tasking. And tasking kind of goes hand in hand with communication between the care team members. At least like, you know, if we're working with NPs, that level of clinician probably has like a care coordinator supporting inpatient care. So a lot of that requires like that framework of tasking. And as we kind of went down selecting our EHRs, we kind of were clear that that's not exactly what we're looking for, at least for our clinicians, but it is something we need for our teams to work well together, because they have very different, you know, day-to-day cut out for them. So that's definitely something that has come in different areas of conversation, not just an EHR, as something for a care team that we would need in like a value-based care space.
Makes sense. So we got another audience question. So what, and for anyone on the panel, what would be the ideal pricing and packaging setup for an EHR? Anything that would sway you and your buying team in one direction or another?
It's like, Corey, do you want to take this, or I can go first?
Go for it. My answer is kind of maybe flippant, so I'll edit while you speak.
Yeah. There's never going to be ideal pricing. I think like we just went through this, and I probably ran like a bunch of different models with our head of finance on like how to think about pricing. The piece of advice that I would give you is really think about the pricing that you're going to need to lock in as you scale. So I think like some vendors price, like by claims, some vendors price PMPM, some vendors like clearly just price maximize. I won't name like which vendor, but one vendor was basically like, we want to understand every single way you make money, and then we'll get back to you with our pricing. And I was like, we will not continue this process with you. In general, I think the easiest way for me to think about pricing is per clinician and like really per prescriber. So, like who is signing and coding and prescribing and submitting orders and submitting claims. Like that's who we want to pay for, because there's so many different people that need to be in and out of an EHR. So I want it to be like core users of an EHR, not kind of ancillary users that we have to manage licenses. And then you can really model that in terms of like, how do you scale? And that is far easier to track than like, how many patients do we currently have on our rosters? How many claims did we submit this month? So I think like that personally for me is like what is easiest to wrap my head around, and really easy from a scaling perspective, not just like, how much are we going to pay this year, but what is like, how much are we likely going to pay next year and the year after? And then is that reasonable? And can we get some type of tiered pricing? The stuff that like is, at the end of the day, I think the stuff that I value is just reducing variability. Like, I just don't want to be in a position where there's some spike in cost that our finance team was not accounting for and is going to like, mess up our numbers for that month or that quarter because we just had like some crazy spike, or, like we had to pay for some new module, like those types of things. I think the other part of it really is like, so Casey, to your question, anything that would sway the buying team in one direction or another. Look, I think that there's certain numbers from a pricing perspective that like, at that point, it does become really untenable. So, as I was thinking about this right now, like, the vendor that we eventually went with is like very expensive, but basically like, the conversation we're going to need to have with them is like, at what point is your pricing so unreasonable that we should just hire a software engineer, and that software engineer could just build a better version of like what you're offering us by using like a more headless EHR. I think like that's the way that I think about it, is that like, does the number get to a size where it literally justifies hiring a full-time FTE at firsthand that could tailor the product to like our use case? And literally we would still be we would be in the green in multiple ways, just based on the efficiencies that we would get from in-housing that, because we're paying this vendor so much money.
Yeah. Thank you for saying that, because I've calmed my approach. It's obviously we want it as cheap as possible, but I think, as you were speaking, I was thinking about how I would want to state that. When I increase my margin, I don't want to give that margin to you, vendor, right? And I think there are too many models that look at it that way, and they hide behind the idea of when you do well, we do well. But I want to get more out of each clinician, and I think the clinician wants to be super powered by the product, and I don't want that to be taxed, basically. And so anything that does like, percent of billing, it basically taxes my margin, and that's hard for me to justify when I scale.
Makes sense. Well, we're just about at time, so I think we'll probably wrap things up here. Huge thank you to all of our panelists for sharing their insights. And this is a topic that a lot of folks care about, have strong opinions about. So really appreciate you all sharing your wisdom, and appreciate everyone joining today, learning a little bit about our product. Please check it out. Let us know what you think. There's a feedback form in the product. You can email me directly, Bobby at Elion.health. And we also have a series of articles coming out about EHR selection. Dhruv and I co-authored one, kind of a general guide to EHR selection. We'll also have one on headless EHRs and what those are all about, as well as a piece on ONC certification specifically, because that's actually insanely difficult to figure out what it truly means to be ONC certified. So a few additional things coming out in the next few weeks. Otherwise, stay tuned. We'll have additional categories here rolling out in the next month or so. And so again, thanks everyone for joining, and we'll see you soon.